Hello, Overcomers, and welcome to this episode of Connect Ovar Coffee. I'm Runsi, the founder of Overcome, and today I'm joined by a new friend of Overcome, Dr. Emil Lou. And look at him, he's all ready with his teal background, and real men wear teal and all that. So what a way to start this session. So thank you, Dr. Lou. So he is a medical oncologist and neuro-oncologist who provides adult patients with cancer care and treatment at the Minnesota Medical School. He is a physician scientist with a strong interest in a translational approach to investigation of solid tumor malignancies at the cellular and the molecular level. The Lou Lab is a cancer research team that believes strongly in supporting community initiatives for cancer awareness, advocacy, education, and engagement of the cancer community, both locally, nationally, and globally. And we love that. So we have a lot to chat with Dr. Lou today about all the fascinating work he's leading that could change the outcomes truly for solid tumor cancers, and so including ovarian cancer. So grab your favorite beverage. I have mine right here, and join us for the, there we
Ready.
go. We cannot see it.
And coffee as well. Cheers.
There we go. And join us for this thought-provoking discussion. And as I always say, please share this video far and wide with anyone who may benefit for all the wisdom that Dr. Lou is about to share with us. And this is a structured program, so we'll take your questions as we go along. So feel free to type in the comment sections below, and we will share it with Dr. Lou, post the discussion, and we'll get back to you with the responses. So with that, a huge welcome to you, Dr. Lou, to this episode of Connect Ovar Coffee. So honored to have you with us.
The honor is mine. Thank you. It's such a privilege. And thank you so much for reaching out and inviting me. I'm honored to be in this forum.
Thank you. So several questions for you because I've read up and I'm fascinated with what you're doing. So, but before we get deeper into our discussion, I know that you're a physician scientist with a strong interest and your approach to investigation of solid tumors at the cellular and the molecular level. So can you tell us briefly about what your lab does and what should we know about it?
Sure. So as you very nicely described, I have a very wide, diverse set of interests that, even when I was applying for jobs, they said, this is too wide, have focus. And my counter argument was, I do have focus. I focus on the kind of the worst of the worst cancers. In my practice, I'm actually seeing patients with gastrointestinal cancers. Gynecologic oncology. Part of the reason that I have been investigating for nearly 15 years is I'm married to a gynecologic oncologist. So I hear a steady stream of knowledge and understanding of how ovarian cancer and many other cancers, colorectal, pancreas, glioblastoma, that have a background in neuro-oncology, they're all different parts of the body, but they have one thing in common. They are basically the worst of the worst types of cancers. They find ways around current forms of drug therapy. And what we do essentially in my lab is to try to unravel these cancers, and what their common thread is how at the cellular level, what the cells are doing, how the cells are communicating with each other, and how are they synchronizing to reform tumors despite the best drugs we can throw at them in the clinic. And we've made a lot of inroads, and I will say my portfolio is vast, but so much of what we do in the lab and in our translational work is actually focused on solving those mysteries in ovarian cancer very specifically.
And wonderful. And that is the reason why you're a guest today. So we have several questions to ask you on that. So what is intercellular communication? It sounds like a very, sophisticated term. So for us, lay it down and make us understand what that means. And why is it important to understand and interpret this communication as it relates to both diagnosis as well as management of solid tumors like ovarian cancers?
Absolutely. So I think of cancer, cancer cells make up tumors, and there could be millions upon millions, or if not billions of cells, but they're not all just cancer, the way we think of cancer being bad, but it's actually like a city. It's a very dynamic city. So I think how I best would address what is intercellular communication, how these cancer cells communicate with each other is no different than in society. We live in cities, we interact with each other, we have computers in our pockets that we use, that the cellular network allows us to communicate through. And if that cell network came down, then we wouldn't have effective communication. We talk to each other, we write things to each other, email or written on paper, maybe more old-fashioned. But essentially what I'm trying to convey is that all this communication is not only effective but crucial for any society to survive.
Mm.
So if you see any city, there were buildings, there were people walking, people are traveling by foot, in cabs in larger
Yeah.
cities or other
Yeah.
means of transport. And all this is a dynamic state. And coming back to tumors, ovarian cancer and other kinds of cancers that form tumors are constantly moving, dynamic state. All of that is predicated on communication. So how cells communicate with each other, intercellular communication, I feel in my time from training all the way until 14 years plus as an independent investigator has been a vastly underlooked, underinvestigated aspect of cancer research that if we could solve it, can maybe help us understand not just what's causing cancer to grow in the first place.
Yeah.
Ovarian cancer, one of those cancers that we know that does not have an effective screening test as of yet. So how is it so insidious to come about and cause symptoms and then be found after the fact? We're already a bit behind. We say the same thing about brain tumors, pancreas cancer, and so many other cancers. There's only, I can count on one hand how many effective screening tests there are for a certain number of cancers. So all the way to established cancers and how they grow, how they spread to other parts of the body, and then how they don't respond to chemotherapy drugs. To me, the common element, especially in ovarian cancer, is how the cells are communicating with each other. They form a synchronous front. They're very dynamic, and they're teaching each other. They're conveying messages to each other, just like human beings will talk to each other and share knowledge, or say, don't take this road, take it a different one because of a detour, like a GPS. The cancer cells are teaching each other how to overcome the very drugs we're using to treat the cancer in patients.
Okay, thank you. So your translational research program also involves identifying those novel biomarkers for chemo-resistant ovarian cancer. So that is a big focus in your lab. So what is the significance of this important work that you're doing as it translates into patient care? Tell us more about this program and the future vision that you have.
Absolutely. Yeah, thank you. So I want to give a shout out to the funding agencies of the research that I'm going to talk about. The American Cancer Society has been stalwart, especially during 2025 has been so challenging for funding, but the American Cancer Society, Minnesota Ovarian Cancer Alliance, and many other entities have been very supportive of this work. I talked about cells a few minutes ago and how cells communicate and molecular pathways that we talk about in so many types of cancers, including ovarian, whereas a target that a drug could hit, a drug that exists, and how can we prove in clinical trials that these drugs work effectively when hitting those targets? And then we think also, how do you translate this into actual applicability? So some of the ways that we literally look under a microscope, look how the cells are communicating, I would say not yet ready for prime time, but it forms a strong foundation of knowledge. And over years, we've made observations of noticing how the cells communicate and their patterns and behaviors of growth that led us to a different stage of looking at tumors that are from human patients. And part of that translating, I have a physician and scientist background and training, and so it allows me to go to the clinic or understand what's happening in the clinic. What are the gaps of knowledge that we need to fill to understand and go back to the lab and design experiments and scientific approaches that go in between? So dating back to at least 13 years, we developed a study that I led in which we enrolled women with newly diagnosed pelvic masses. And as you know, and as your audience knows, not all masses in a woman's pelvis or a human's pelvis are going to be ovarian cancer, but a certain percentage of them are. And so we enrolled people with newly diagnosed pelvic masses and examined a lot of things under the microscope, from the tumors for the ones diagnosed with ovarian cancer and the type of ovarian cancer, studies from blood, looking at different markers. And something that emerged was something as simple as the slides used to make the diagnosis. We actually looked at it as an even deeper layer, and we're able to associate the patterns that you would look under the microscope with eventual prediction of whose cancer would be resistant to platinum chemotherapy, which is the backbone of ovarian cancer treatment, or potentially sensitive thereof. And something like that is something we expanded upon over the years, and incorporating artificial intelligence, larger cohorts, having more established collaborations internationally with colleagues from Europe and elsewhere. Where we are ideally marching towards is to incorporating such a biomarker that can be effective and actually quite cheap because it's a slide already in existence. Be able to interpret that with AI assistance into large-scale clinical trials to validate this and maybe incorporate what value this would have would be immense if you can know at the time of someone's surgery or a biopsy that the chemotherapy 1 in 4 times platinum resistance is destined not to work. The idea is to spare someone of the side effects of a treatment that's not going to work,
Yeah.
and perhaps consider clinical trials or other routes of treatments that may be more effective and spare someone of the toxicity associated with those drugs.
So I'll build upon that. What you just shared with us is oftentimes, in this forum or elsewhere, some of the doctors we talk to, they will tell us that even though research will tell us something, or AI will come up with something, some information, we don't know yet what to do with that information, because the standard of care is a standard of care, and this is how we treat patients. And so, okay, we have this new, very new information that we have never received before, but we are not quite sure how to take this information into clinical practice. So similarly, when you know that, okay, this patient is probably going to be chemo resistant, platinum resistant, versus this patient who is going to be sensitive. At this point in time, if this, what I'm trying to understand is, let's say this goes into clinic in the next couple of years, and everybody has that information. Do we have the treatment practices in place to then channel the patients accordingly, or do they still follow the same regimen that they are doing now? So, because what I'm trying to say is, your fantastic research, is the treatment going to keep pace with it, or are you ahead of your time? You know what I'm asking?
I like that term. I may make the humble suggestion that I may be ahead of my time and my researchers and collaborators. But in all seriousness, every cancer is different. Sometimes I'll say the overall landscape in the last 10 years is become so much cheaper and so much quicker to do what we call comprehensive genomic profiling, right? To uncover genes that would be targets for drugs that exist. But in so many types of cancers, and ovarian cancer is no different, but so many types of cancers, we can identify hundreds of genes, but very few that mean anything in terms of exactly what you're talking about, what we call actionable findings. That there's a drug that fits a target first, and that they have gone through a clinical trial to show that there's a clinical benefit, whether that be in shrinking the tumor, what we call response rate, does it increase the amount of time before a cancer progresses, we call progression-free survival, and how long someone lives, overall survival. So I think ovarian cancer is in good company with so many other cancers. We're trying to do that. But what's really fascinating, I would say very promising, in the ovarian cancer space across the board is increasing approvals since 2018 of tumor-agnostic treatments. And I think this is where it's not just the future, but it is the present and recent past few years of oncology. And it's only going to expand more. This realization that the biology, when we look under the microscope, the cells or the tumors, there are patterns that are common across many tumors. And some of that, so much of the attention has been on the genomics of it, that the centerpiece. But I look at it as a cancer cell biologist, or I call myself a clinical cancer biologist, to understand here's a translational aspect of need, but don't forget the cellular patterns that also we can develop drugs and design drugs to target. But what's fashionable is the genes, and you identify a target with a that could be hittable, whether usually it's the target on the outside of the cell, and maybe are a little more difficult targets that are inside of the cell, but nonetheless, drugs that would fit the target like a lock and key and shut down the machinery of a cell, and then all the cells, and then thus the tumor would stop growing or maybe shrink, and that would be the ideal. But so many of these classes of drugs, and of course, immunotherapy is always at the forefront of people's minds. It's on the tip of everyone's tongues. For any cancer, it is very common to hear in any oncologist office, am I eligible for immunotherapy? Can I get immunotherapy? And we need to learn more about what markers might predict how well immunotherapy can work. But that's an example from 2018 where the FDA approved tumor agnostic approval, meaning it wasn't specific to only one type of cancer. The studies may have started in colorectal and even uterine cancer in the GYN oncology space, but is now approved for anyone who has a certain marker. What I'm referring to is deficiency and mismatch repair, microsatellite instability that's present in a minority of patients. It doesn't guarantee the immunotherapy will work in that case. And that's the case for any targeted therapy. There's no guarantee will work, but there's a higher likelihood. And identifying these biomarkers is crucial to the future of oncology and how we can borrow. And as a solid tumor oncologist, how do I learn things from one cancer and apply it to another cancer like ovarian
Exactly.
cancer? Part of our
Exactly.
mission.
Wonderful, thank you. Speaking of, you spoke about biomarkers for a second. So, your would love your insights on the gynecologic cancer genes and biomarkers that are currently being used, and you can borrow from your wife's knowledge here and the future direction in terms of improvements and progress. And so, I feel like, and I think you will agree with me, that we have definitely not identified all the genes that are responsible in causing these cancers. So how can we get better?
Yeah, so the widespread, more equitable access to genomic profiling, not that I would say it's cheap, but it is certainly faster and cheaper as a field compared to 5, 10 years ago.
Yeah,
And also the I would say the maturation of technology, again, usually through commercial means of tech checking cell-free DNA. So it's still of great fascination to me, and we've been adapting this into our work in ovarian cancer and other cancers, is looking at the fact that cells, these cancer cells from tumors, will shed DNA into the bloodstream. And our heart pumps our blood throughout our body, and that's how cancer spreads from many types of cancers. Ovarian cancer is more limited to the abdomen and pelvis, but when it gets to the bloodstream, that's when cancer becomes even more dangerous and can spread. But leveraging that technology and be able to, with good sensitivity and accurately checking that, what are the amounts in the bloodstream, is an example, borrowing from experience in the leukemia and lymphoma world. How can we apply that to ovarian cancer, colorectal cancer? It's still very much a moving target, but there are trials ongoing and questions being asked. How do you leverage this? And then when you get the DNA check, you can check the genome just like you check in the tumor, and that it's coming closer in more recent years to almost 100% sensitivity to match whatever testing you would look for genes, potential targets for therapy in tumors. The blood-based technology has really improved a lot in the last few years. So how do you leverage all of that, not exclusively one or the other, is really key. And certainly the genome of ovarian cancer is very different than pancreas and very different than lung cancer. Lung cancer is a paradigm. When I was in training many years ago, Morrison Kettering was a time when stage 4 lung cancer became a death sentence. People would be thought to die within months. To now you have long-term survivals, many years, half a decade or more, well more than that, for patients who have alterations, even if it's only 5 to 10% of that population, if they have the target that fits the drug that is effective and proven to work, people can last and live with great quality of life for a really long time. And that's where we want to get with ovarian cancer.
right.
I do think the caveat for ovarian cancer is it won't just be the genome, but hand in hand, understanding the cell biology and how the structure of tumors is built may go hand in hand. And I think some of the drug classes coming forward are starting to recognize that fact.
Thank you. So as I said already, that you are probably ahead of your time. So you are like researchers, like you are almost always at the forefront before all of us catch up to you. And so, from your lens, what excites you today about the therapies of tomorrow that just evolving and emerging? And we also briefly touched upon it, but how do you see the role of AI evolve into making detection, treatment, as well as survivorship far better than it is today?
Absolutely. I'll start with the AI and work my way up
Okay.
to the
Yeah.
top of the question list. When I mentioned artificial intelligence before, I would say it's a brave new world. So we
Yeah.
collaborate with world experts in AI, and basically I approach it saying, I don't know anything, but teach me about your expertise. And in turn, where we get the synergy is we come with the oncology and cancer research expertise. And these are experts, computational biologists who want to apply the technology and their findings in AI for the greater good. So when I was talking about AI, how we apply it so far, it's not necessarily asking questions of it of how to manage a patient, but more
Mm.
so literally scanning digital images of slides from biopsies and surgeries, and training it to do what a human could do more effectively, an expert pathologist or a scientist in my lab, but to do it much quicker. And that's where we hope the path to the clinic will help, because it is sometimes a tedious process. And it's an inexact scientist sometimes, but I think the AI, training it to be as 100% as accurate as possible, will help accelerate that process. But there
Right.
are so many ways. I have patients who use AI to look at their pathology and the imaging. They'll put it into AI and they will Of course, there's always going to be an answer, whether it's accurate enough or accurate enough for that patient may be a different issue. Looking up medical information and how we apply it in the clinic is maybe my answer today will be, I don't think I have a great answer today, but maybe 3 months from now, maybe 13 years from now, it will be a world different just because of the absolutely fast pace that AI development is
Exactly.
moving. It is, I mean, I think day to day, literally, and the different platforms, but it's maturing at a much better rate. So I think there's a lot of great things to come, but I think we have to always coming back down to the human being with expertise and the patient knowing their own body is how to best interpret it, not leave the
Right.
final adjudication to AI.
Absolutely.
For drug classes, we mentioned tumor agnostic before, and of course, immunotherapy is exciting, but there are so many other classes also. Something that's really, I would say, the next wave that is already ongoing, but now expanding, and the types of drugs under this domain are called ADCs, antibody
Mhm.
drug conjugates. And I think that's fascinating for a number of reasons, but this idea of leveraging the immune system, I mean, these are ideas that are 100 years old. Using chemotherapy, obviously, chemotherapy has been around for a long time, but merging them in a very sophisticated way in the era where we know whose tumors have what targets and whose
Mhm.
tumors do not is a more intelligent design and a more intelligent strategy that we've ever had before.
Yeah.
So the example I would say is the FDA approval years ago of mirvetuximab. So the
Mhm.
long-awaited, or I would say the sentinel, maybe with more to come, wave of drugs to finally address this question. What do we do in cases of platinum-resistant ovarian cancer, where it's just stubborn and comes back in a
Yeah.
short amount of time, defined as under 6 months? Well, we've never really had a great solution, and that's one of a number of drugs that are emerging. It is an antibody drug conjugate, but I think it's interesting because some of old chemotherapies that may not have worked when injected or infused through the vein may work more effectively when you have a homing signal, a missile basically, which is that antibody that's attached to and homes in on the cancer where the target is located, and then
Yeah.
the chemo can work more effectively. The whole complex, as we call it, is absorbed into the cells and then explodes the cell, implodes the cell from the inside. And though in a very unique way, it's chemotherapies that may not have worked by themselves. The antibodies may not have worked, hitting the target may not have worked by themselves, but you put that combination together, and mirvetuximab is a beautiful example of that for patients with ovarian cancer. And I think it's part of a revolution that is ongoing, and there's more story to be written. That's just one of many examples, but we are seeing a lot more treatment options for our patients in ovarian cancer, and that's really exciting.
Yeah, and then with the MARV though, the only thing right now is it's tied to the folate receptor alpha, positive or negative, right? That's the, I mean, we want to move to a state where ADCs are available to every patient, regardless of their, folate receptor alpha
Mhm.
um, disposition, right? So that's when will be able to use it widespread and help as many patients, because from my understanding there's only a limited percentage of patients that are 70% or over positive for folate receptor that MARV requires, I guess. But now what I also hear is they're sequencing the next generation of the drugs where it will have a broader implication, in the sense broader acceptance rate, and many other ADCs are in the manufacturing. So good times ahead, I guess, with the ADCs, which
Absolutely. It's a
is
great start. If we
yeah,
consider a start, it's a good start, and it has to be built
absolutely.
again through research of understanding each individual patient's tumor. How can we identify it to the best of our ability? Again, I'm a believer in looking at tumor features beyond just the genome, but merging them together with that understanding. How can we target and tailor therapy for each patient?
Yeah, and I did not have this question written up, but it just occurred to me that you work with brain mets as well, right? So with ovarian cancer, typically it doesn't go to the brain. It does not. But we have also encountered a few patients, talked to a few patients and families where it did spread into the brain. So do you have any information or insights to share in terms of which types of ovarian cancers typically will spread into the brain, and what is it that our overcomers need to know and ask and their providers in terms of when they're in their advanced stages of the diagnosis?
Absolutely. And as you point out correctly, it's It's not very common, but
Mm-hmm.
when it happens, it is something that really needs to be addressed urgently, in the clinical
Mm-hmm.
setting. I would say, starting with clinical symptoms, it's easy to overlook them, especially with all the other combination of platinum or
Yeah.
other, treatment-related side effects or potential. But people might say, I have a headache, I feel dehydrated. Their headache doesn't go away with Tylenol or ibuprofen, and something's amiss. Of course, an extreme might be seizure, but a mass in the brain interrupting the brain's normal activity in space can cause a seizure, headache. Those tend to be the most common side effects or among the most common side effects. Neck pain or blurring of vision are just a couple more examples of things. And if you ever develop any symptoms like that, it's really important to recognize them, bring them to the attention of your medical team. And if it's not offered to you to have a brain MRI or it's not being considered, then I think it's more than okay to bring up and say, is
Yeah.
there a possibility that I have a ovarian cancer metastasize to the brain or to the spinal fluid? And those are with the pain or in the neck or in the back, those are things to consider. Other areas I always include central nervous system. We bundle the brain and spinal cord. I'm always very worried because one of the few cancer emergencies that we talk about is cord compression. When cancer goes to the spine, that could be a medical emergency, and it's not something to wait on going to the emergency room. If you have back pain or numbness in the groin area or sudden weakness of the legs that occurs over minutes or hours or within a day, certainly are things that are emergency room material. There are ways to treat them with experts, including a multidisciplinary team that might include radiation oncology team members or neurosurgeons or the equivalent. So there's really a combination of folks needed. It's very similar ovarian cancer. I would say high-grade serous ovarian carcinoma is the one I link most to potential for brain metastasis. It's very similar to colorectal cancer. So, and a phenomenon I see there, I think is similar in ovarian and other cancers that are not common to go to the brain, like melanoma or non-small cell lung cancer, 40% or upwards will at the time of diagnosis or later during the course. But colorectal cancer, only 5% on paper. But in
Mm-hmm.
my own practice, I see a lot more of that. I know I'm also a referral specialist, so I tend to see
Yeah.
more of it as a bias. But what I think may be happening is the double-edged sword. The success of many forms of treatment are allowing patients to live longer than ever with intact metastatic disease, but manageable. But I just think, and I would say, I know there are studies out there. I would say just my own impression personally is that people are living long enough to be successful in staving off the cancer, maybe this part of the body, but then it provides opportunity for the cancer to spread elsewhere in places that traditionally are less common.
That makes sense. That makes total logical sense. Thank you. I was recently reading on the impact of this lingering COVID symptoms that may impact treatment outcomes for patients that are undergoing cancer treatment. So that's a bit concerning, I feel. And so, what should our overcomers know and ask about this to their healthcare providers? Because by this time, all of us probably have had COVID once or twice or more. So, what is it that they need to know and talk to their providers about?
I like this question because I understand, obviously the zeitgeist the last half decade has been controversial about vaccines and whatnot, but it is an infectious disease. It has emerged, not emerging, but it has emerged. But now we hear so much more about this, that the symptoms that cannot be pinned down on anything specific, and in patients working through cancer and their cancer journey that don't quite fit in terms of the cancer or side effects of the treatment. I think it is something that we do have to worry about potential long COVID syndrome, but so much is yet unknown. From my group, not as an aside, but again, towards that idea of quality of life of patients, we published last month a paper in a journal called iScience, a story about long COVID. It was actually in 3 patients who were immunocompromised from the peak of the pandemic in 2020, patients from our hospital at the University of Minnesota who had COVID very early on in the pandemic, so severe that it required hospitalization. They had such a severe immune reaction. And we actually zeroed in on patients who had any form of biopsy material prior to and following COVID and that severe COVID inflammatory reaction. And we did a very heavy set of genomics on it at different pockets of the tumor called spatial genomics. And we learned a lot. And I think part of what we learned was that the gut, the intestines, regardless of type of cancer or what was being addressed, it serves as a reservoir. And that's not an entirely new concept. It's something postulated and shown in a number of other studies over the years. But this idea that, like herpes simplex virus, is something that 90% of the American population is exposed to in times of stress. Some people more than others might have oral sores or other types of symptoms, but it resides in the back of our brain, somewhere called the trigeminal ganglion. That's just a fact of that virus. And now I think we're learning that maybe long COVID may be a result of COVID doing the same thing. It goes and becomes dormant. It's not actively causing COVID infection constantly, but in times of bodily stress, stress imposed by cancer, stress imposed by the treatment to treat the cancer, if it awakens and causes more havoc in the immune system, is that something of concern? That's something we learned through that study and made us concerned that there were certain gene signatures that were coming up that could potentially be associated with a longer term inflammation. And so there's a lot more to pull the thread on, a lot more to be discovered, but that's something we were looking at very specifically in an immunocompromised population of patients with cancer and hope to build on that. But I think that long COVID is a legitimate item of concern. We just don't know yet what to do with it. From a practical standpoint, I'm a proponent of vaccination for influenza, especially this time of year when it's available. In different pockets of the country, it's available at different times. But if interested, you can ask your treating oncologist or care team. I would say the same thing for COVID-19 for any of my patients who are interested in just trying to boost their immune system to the point where they can stave off the infection if possible or decrease the severity of it.
So, so you're bringing up very, thought-provoking points, because I was just thinking when you were talking about the COVID lingering and, disrupting the treatment outcomes, right? And so, by all these inflammation that's happening in the body silently. So by that logic, it will probably disrupt immunotherapy treatments, because if it is active, if it's triggered, immunotherapy is not going to be as efficient because of that lingering COVID inflammation and the triggered activated state. Is that right?
I think so. I don't have proof, and I'm not aware of studies specifically in patients with cancer getting immunotherapy, but I think what you're describing makes sense to me. More to be discovered and more research needed, but it is a worry. It's what actually the research question, sometimes we ask a research question, we go in one direction and find something else and go in a completely different direction.
Right.
That project was one of many examples. We actually were looking to see if patients with intact cancer, the severe inflammation reaction against COVID actually had anti-cancer properties. That's actually how we started this question. We found that wasn't the case, but then we were like, oh wow, this inflammation is raging in this patient population, and wow, there's actually a lot of harm being done here potentially. And also, by the way, the gut served as a reservoir, whether it be a month in one patient or multiple months in at least one of the other patients for a really long time. And we didn't think it would linger or that we'd find it there and cause this cascade of genes that potentially could signal inflammation in the longer term. Again, it's coming back to intercellular communication. So for me, that's why it's a central pocket of research, whether I'm speaking about COVID or cancer or ovarian cancer or pancreas cancer or glioblastoma. It's a central thing. It always comes back to communication, and I'm worried that long COVID may have longer impacts than we yet know, but research will need to uncover.
That makes sense. Thank you. So you have also been in the news for leading this breakthrough investigational immunotherapy trial for this young stage 4 colon cancer patient, right? And many congratulations for your work. And can you tell us more about this achievement? What happened? And most importantly for our community, a breakthrough like this, could it be replicated for solid tumors like ovarian cancers? Why or why not?
Absolutely. I'll start at the end and saying we were many researchers much smarter than I am here at our university who drove the clinical trial that you just mentioned are working very specifically in trying to translate that to ovarian cancer. So I want to ensure to be able to say that the work is ongoing and very, very promising. So we talked about biomarkers and you talked about, well, what if someone doesn't have a biomarker target? Let's devise ways and strategies where therapies can fit regardless of a target. And so for at least 40 to 50 years through the National Cancer Institute, Dr. Steven Rosenberg, amazing pioneer, looked at taking someone's cells, immune cells from their own tumor and basically supercharging it in the lab and making it more potent and giving it back to that person. And so that's something, it's not a new concept, and there have been varying degrees of success. It's not been 100% or 50% or 20% of patients, but there were good signals of remarkable response in patients with different types of solid tumor cancers. Not necessarily ovarian, but there's a promise or there's a potential that that can be applied across the board, whether someone has an ovarian or other type of cancer. The premise of this trial was to apply cell therapy, but also acknowledging that what we talk about immunotherapy in the clinic is really a specific class of immunotherapy called immune checkpoint inhibitors.
Mhm.
And it's usually only going to work more effectively in some cancers more than others, but if they have a biomarker, microsatellite unstable, again, we talked about earlier in this conversation, only seen in a minority of patients. PD-L1 is a signal on cancer cells that immune cells called T cells will latch on to. So those immunotherapies, pembrolizumab, nivolumab, and others latch on and break that chain, and it'll unleash the immune system in that way. They're breaks. But there are other forms of immunotherapy. If you take a whole cell, an immune cell from someone's cancer, and re-engineer it instead of being dormant and just leaving the cancer alone, can you reconfigure it? Can you reteach it to go against the cancer? Is a principle. And there are targets that are on the outside of the cell and targets inside the cell. And so research here at the University of Minnesota, in collaboration with the National Cancer Institute team that I just mentioned, led to this very promising clinical trial. It identified a checkpoint. So instead of being on the outside of the cell, it was on the inside of the cell. It was called CISH, CISH for short. And so you can't take an antibody like an antibody drug conjugate or immunotherapy, and it won't work to get inside the cell if the target's there. So we use CRISPR genetic engineering, which I know has been very much in the discussion and of curiosity, but it has really made a big difference in science over the last decade. I think of it like genetic scissors. CRISPR is not a therapy in and of itself. It's a means to an end. It's a technique used to more precisely edit genes. And in this case, we used CRISPR gene editing to remove that blockade gene that was inside the cell called CISH, with the theory that the T cells would suddenly wake up and be able to be infused back into the patient, very ones that come from the tumor. So this trial was built towards enrolling patients with metastatic gastrointestinal forms of cancer, and it happened that almost all had colorectal cancer, having received the standard of care, multiple lines of chemotherapy or drug therapy that no longer worked. In at least one case, someone who had received immunotherapy and it no longer worked. And so the case that made the news, we presented at the American Association for Cancer Research annual meeting on April 29th, published in the same day in the journal called The Lancet Oncology, and it made a lot of news, as you mentioned, which we were very happy for. A very specific patient who was interviewed. She was a young adult with early onset colorectal cancer in her 20s, had tried essentially everything, every available standard of care chemotherapy, and her tumor actually had microsatellite unstable form of disease, but no longer responded to immunotherapy. And after the first 1 to 2 months of infusion of this engineered cell product, again, immune cells from her own body that were engineered in the lab, infused back into her, led to a clinical complete response. And that has lasted 2.5 years plus to date. I saw Nick last month, and she's doing remarkably well. And after going so many years of basically constantly having to be in the medical system and clinic, I'm thrilled for her because among many things is she gets her life back, her quality of life.
Absolutely.
And the things that she loves to do, she doesn't have to spend that time in infusions. She can go in the community and do everything that she likes to do. Of course, this was just one patient, but we want to understand biologically, and we still have ongoing studies in many facets to understand at the cellular and molecular level and everywhere in between what happened here that we can recapitulate, not just for helping patients with colorectal cancer, but some scientist colleagues, the same ones who do the genetic engineering and pioneered this research, are working very specifically to try and translate this to ovarian cancer in a clinical trial and other types of cancers as well, and see if we can recapture that success, which we hope. And I think it's also important, it's the first, to my knowledge, successful example where if someone's eligible for immunotherapy and it works, it's not the end all and be all because cancer is smart. It figures a way out. So in this case, like with her and many other patients, immunotherapy works like any other drug until it no longer works.
Yeah.
Standard of care next, no one knows. But this might show a promising way to do immunotherapy with a different tactic, going after CISH with CRISPR genetic engineering and other formulations on the way. We collaborate with the company that sponsored it trying to find new formulations to democratize access. And maybe the next generation of that won't be the arduous cell therapy process, but maybe an infusion through the vein. And that might allow us to do more widespread clinical trials and more types of patients with different types of cancers in the future. So
This
more to
is
come.
so, yeah, this is so hopeful. Thank you for sharing all this information. And also fantastic to know that there is an ovarian team that's looking into translating this perhaps in the ovarian space. So that would be so wonderful. And so, I'm also curious to understand because I understand Lynch syndrome could have some shared, risk factors between ovarian and colon, because this particular case was colon cancer, right? So, but there could be some overlaps between ovarian and colon cancer, shared risk factors, genes. Um, so tell us a little bit about that, the overlaps between the colon and the ovarian cancers, and especially for, let's say, I'll break down my question. So let's say that someone has a family history of ovarian cancer. Could that person be, because we then focus only on the gynecologic cancers, but then could that person be, diagnosed with colon cancer instead? Or what are the overlaps? What should we know about? What are the things to monitor here?
Absolutely. I think knowing your family history, and if a family story is built that leads
Yeah.
to a diagnosis of Lynch syndrome, and then you also have the people who already know it, that Lynch syndrome is in their family, maybe as an individual they get tested. And that can be a frightening thing to say, I might have potential for having cancer at all, let alone multiple forms of cancer here, here, here. And Lynch syndrome, as you stated very well, colorectal cancer, uterine cancer, even some forms of brain cancer, and others. It creates a very daunting prospect. But I think certainly any cancers, I put breast in there as well. But although it's not the only risk factor genetically that could be inherited for those cancers, it really heightens the importance of early awareness, meaning early in one's
Yeah.
lifespan, and not waiting until, for example, the age of 45 for a colonoscopy. And this is under the guidance of an experienced medical team would be really important, integral to care in our center. And many centers have access to cancer genetics counseling, or we call it cancer risk management. And these are very appropriate and very helpful experienced genetic counselors who are trained in exactly this scenario, as you said, about patients who have known cancers, but also family members who may have Lynch syndrome. And how do you devise a plan? How do you attack this with a plan and a schedule, saying at this age, get this test, get your first colonoscopy? Maybe not wait 10 years, even if there are no polyps. Maybe it needs to be done yearly for a few years in a row or every few years. Again, they have the experience, and our genetic counselors do a fabulous job of mapping out in year this, you do this, and next year you would do this, and let's have checkups this frequently, whether it be multiple times per year or yearly or every other year, depending on those test results, is absolutely crucial because the idea, the notion is to capture cancer and find it as soon as possible, ideally in its earlier, more potentially curable stages than later
Sure.
stages.
Yeah, that makes sense. And so, um, since we talked about and you study cell communication so closely, right? And you also talked about cancers appearing in one organ versus the others, right? So, how does this intercellular communication work in the disease spreading to other organs? How are the cells talking to each other and devising their way into our bodies? And how, most importantly, actually, how can we disrupt this communication and block off their pathways to talk to one another, cut that telephone cord, so to prevent the cancer from talking and spreading to
That
the
question, yeah, absolutely. I'm sorry, go ahead.
no, that was my question.
I
Yeah.
was going to say, I was excited to jump in because that statement is music to my ears, and I've been saying it for 15 to 18 years. And sometimes I wish the grant reviewers would understand it as very clearly as you do, that notion of understanding how and why the cells are communicating is a potential therapeutic target. It
Exactly.
talked at the very onset of the hour how communication is important for social dynamics among people and civilizations. And can you imagine if all that communication was shut off? We wouldn't be able to function as a
Right.
society, right?
Right.
So
Right.
this really is no different for cancer and cancerous tumors. If you shut off the communication, the cells will be existing in isolation and basically shut
Yeah.
down their ability to function as they normally would. And that's a very impactful therapeutic target. It's not necessarily something that's, or at all, that's going to come up on a genomic screen, but we're trying to basically create a new class of targeting, cellular communication. There are different forms of cell communication that we study, again, under the microscope or in the lab. Some of the examples I would use is the cells will create doorways if they're immediately next to each other. So basically, it's when you're in two adjacent rooms and you open the doorway, and you walk through, you're communicating your body. In this case, you're moving through. Cancer
Mm.
cells do that. Something that we specialize in and have looked at ovarian cancer. We were the first to show existed ovarian cancer over a dozen years ago. Was a very serendipitous observation is that cancer cells will form in ovarian cancer very specifically, as well as other cancers, form skyway-like projections. So if you know whatever city you live in, but in Minneapolis, they're very prevalent, Minnesota, because of cold winters, buildings that are far apart above the plane of the street, there will be
Yeah.
ways or projections where you can walk through, even if it's 0 degrees or -10 outside, you don't need to bundle up, but there's a 100% chance you will make it to the other building, which is not next to that building you're in, but across the street, if you keep walking. And cells will form this, and they're called tunneling nanotubes. And I discovered this in my postdoctoral fellowship at Memorial Sloan Kettering. It was very early in the field, but we were the first to show it in human tumors, starting with lung mesothelioma, and we were the first to show it in ovarian cancer. And these ovarian cancer tumors will form these networks that we're trying to understand what causes them to grow. And then once we figure that out, what are the components? How can we target them effectively with drugs that exist or drugs that can be designed to abrogate that? And then in terms of going, I would say the examples I gave of communication are multiple ways that tumors confined within themselves can do and stretch out into the organs where they already are, within or outside of the ovary. But how do they get to other areas of the
Yeah.
body? The belly, they go into the bloodstream, as I mentioned earlier. There are yet more signals all under that umbrella of intercellular communication. Again, another thing that was maybe characterized 10 or 15 years ago that was thought to be garbage bags of the cell, but are actually little blips that come off of, little sacs that come off of cells. They're not just garbage bags. They are literally containing signals or information to plant the seed, make a fertile environment for cancer growth and spread in the lungs, in the liver, sometimes other parts of the belly, in the abdomen and pelvis in ovarian cancer. And that fertile ground, so to speak, allows the cancer cells to stick and then create new tumors as a result. And so that's why I think that these different forms of communication are so important to understand. And I think we're not yet as a field where we can define exactly how to drug them at targets. So we're not yet ready for prime time for the clinic. But I think when we get to a point where the most solid understanding is a time to understand how can we do drug screens. And that's part of what we do in the lab is building platforms to how do we screen these effectively using existing drugs and maybe design drugs in the future that can effectively target and abrogate the entire communication network to allow tumors to shut down. So I find it very exciting, and I think the struggle is always real in terms of having the funding to support the ideas. There's no shortage of ideas and approaches, but we always depend on funding mechanisms and grant agencies and patient advocacy organizations that are so supportive in important, what we call high risk, potential for high reward type of research.
And this work is, it could truly change outcome for cancer treatment and in the diagnosis as we know it today. So if you crack the code and one day you win the Nobel Prize, remember that you came here and we talked about this. So.
I would be honored to come back anytime. I would be especially honored to come back and share first dibs if I get a Nobel Prize for sure.
This is an amazing piece of work that you're doing, Dr. Lou, because this is logically, even for people who are not in medicine, it makes sense. It makes logical sense, and that this is how you disrupt the communication patterns, and this is how you tell them to just kind of ward off and go to your cell and die, kind of a thing, right? So yeah, I mean, I'm keeping my fingers crossed for many more breakthroughs to come in your research. So thank you for the work that you do. And just, we have talked about a lot of things, good things and hopeful things, but in terms of like just getting real for a second, what are the challenges do you see in ovarian and particularly ovarian, but in gynecologic cancers overall, that you feel it's still very unmet and we haven't really uh, considered?
Yeah, there have been many strategies examined in the ovarian cancer space over the years, like certainly a minute or more than a minute of intraperitoneal chemotherapy, and that's it is borrowed from, and other cancer types have borrowed from that experience, and that that's wavered in the wave of drug therapy and immunotherapy. Again, looking for more genomics, so that is ongoing. Where I see potential inroads, and of course, like many other types of cancers, trying to create effective, sensitive screening tests is crucial. Can ovarian cancer join the cadre of breast cancer, where there are mammograms and other modalities for doing that, colonoscopies and other forms of colorectal cancer screening, cervical cancer screening, right? But then we're running out of ideas and proven validated methods. So could ovarian cancer join that with the maturation of cell-free DNA? That's a blood test. Is that something that could potentially be predictive that if somebody had a certain signal that might warrant imaging or other higher investigation that would be fruitful in finding ovarian cancer earlier, that would be a really important advance, right? Because we don't want, I think any oncologist would say, we love to put ourselves out of business. We don't want to be in a position of having to tell somebody you have a stage 4 form of cancer, it's not curable, it's manageable with whatever therapies, but we're just trying to stave off a freight train that's out of control. We want to try and find it sooner and get it at its soonest available vulnerability. But for those cases that are further along, high-grade serous ovarian carcinoma just comes to mind because that's our major focus, but there's quite a vast array, right? There's borderline and others, and so there are a lot of nuances. In discussion with my gynecologic oncology colleagues who are on the front lines and doing the surgery in these cases. But for the high-grade ones, when they talk about the maximum safe debulking or suboptimal debulking, I think that's a space where definitely potentially improvement can be made in terms of tailoring what is the exact therapy that would be most beneficial. Whereas traditionally it's been platinum or bust, platinum combos
Exactly.
and more. And then some agents are making their way into the space, but maybe there are drugs that could be more effective beyond the intraperitoneal chemotherapy strategy, that if suboptimal debulking, despite the hands and eyes of the best surgeon anywhere, there is more therapy needed. What could be most effective towards infiltrating? Again, it comes back to me, the cell biology of the tumor. What drugs would be most efficient in penetrating the tumor that's left over? Optimal debulking is more scattered cells. What drug strategy or combination of therapies would be most effective in those situations? So
Right.
the clinical field is not there yet, but I think there's ripe opportunity to ask those kind of questions in a research setting and begin to translate those into trials in the coming years.
Absolutely, because the way I see it is everyone's cancer is different. I mean, it's unique in their own ways because, no one is a statistic. That's what, because we typically kind of say, okay, stage 4, stage 2, stage 3, but every person within that stage operates in their own, their body operates in a very different way from the very next person who has the same exact cancer. So, the more we can get personalized, like you're saying, the better the chances are that we are going to get to a complete restoration of health and move on to the next phase. So you talked about the CRISPR or CRISPR, however you pronounce it, the gene editing as the genetic scissor. So just in one sentence, because I was kind of curious to know about that, what is that technique? Tell us a little bit, just a little bit. Yeah.
Yeah, so it led to the discovery of Nobel Prize in the last decade, which is an amazing
Yes.
advance. It's basically it's an immense improvement upon previously existing technology, where you could take a gene and remove a small part of a gene or entire gene, but really with great more precision than was previously allowable. And so in this case, I mentioned for the clinical trial,
Yes.
that gene created a product that prevented the immune system from being potent enough against the cancer. So in this case, the purpose was to remove that gene entirely. And
Yeah.
so it was used towards that end. That's why I call it genetic scissors.
No, that was very, very easy to understand. So that thank you for saying that, because sometimes when the terms are too technical, it doesn't, it's hard to grasp your head around it. But genetic scissors, I instantly visualized it, so it worked. Thank you. So what keeps you? We are almost at the top of the hour, just in the next few minutes. What keeps you excited and hopeful, Dr. Liu? You're doing so much work, but what is it that keeps you the most excited?
I think conversations like this, because I think any of us in the lab or in the clinic, I think it's too easy to get immersed too much into the day-to-day, the stuff that is, bureaucratic about medicine.
Mm,
Obviously, research is slow. It's not something that we make a huge discovery every day. When I had my first research experience as an undergraduate, a very prominent researcher whose lab I was in told me, if we make a major discovery once a decade, that's a lot. And I'll be, whoa, it almost dissuaded me from going to research, but it was a powerful lesson. It's built day by day, week by week, and month by month. And I think just having that North Star for us, and as you described very well, that our lab, I never want our lab and our team to lose sight of why we're doing this. It is not for just to get a publication or just to get more grants. The whole purpose is to help alleviate human suffering. And sometimes, whether it's at the microscope on a Saturday or we're doing something and learning about CRISPR or new techniques, the entire entity revolves around what are we doing to make a difference, to move the needle. Sometimes, or most times, it is very small and incremental in advance, year to year, and maybe even decade to decade. But hopefully, the small incremental advances add up to something more substantial, in which we get to a point and say, with this body of work, we've made a difference in the knowledge. Now we can do something about it to help human patients. And so that's why collaboration is so essential. There's no one should live on an island, and we have a vast array of collaborators, not just throughout the US, but throughout internationally. And I'm always kind of acquiring and reaching out to people like the AI expert I mentioned, Dr. Matabushi. We have an ovarian cancer study under review, exactly that project where we looked at large scale AI looking at tumors. Can it do with as good precision, but even more quickly what the human eye can do? To me, that will be a large step towards clinical trials. And clinical trials are always a way station towards improving the human condition and outcomes for all of our patients.
Absolutely. Thank you. So I have asked you a lot of questions, Dr. Liu. We've had a fascinating conversation, but is there something that I missed asking you that you would like to share with us?
You're very comprehensive. So just speaking to you, to thank you for this amazing forum, and to all the listeners and home watchers out there. I guess I always want to leave. I'm an optimist. The glass is always full. I'm always looking, how do you
No,
fill
there's a question that question is coming, but
oh, that question's coming. Sorry.
yeah,
I won't
that
leave you.
question
I'll
is
just
the last
say,
question I always ask. But is there anything scientific or treatment wise that I've missed asking that you would like to share with us, or um,
yeah, I think we fit in a lot. We talked about the genome, we talked about tumor biology that's not testable on genome, but how I think they're synergistic, and we have to recognize that they can be synergistic, and how we can use that knowledge. And I think kind of blindly going after drug design, I'm talking
yeah,
about pharma. And in academics too, we have to be savvy and really think of strategy and tactics and how we do intelligent design tailored to the population and the type of cancer. And then
exactly.
eventually that filtering down to how can we tailor to each individual human patient to give them a treatment that could potentially work best for them, is a way I would summarize that.
That's a wonderful summary. Now this is my last question that I ask all my episode guests: is what message of overcoming would you like to share with everyone listening today?
Yeah, so you and all and everyone watching, I think, are a really deep source of inspiration. I think you manifest day to day, and in forums like this and in that discussion, overcoming is very empowering, right? It's about empowerment. It's about knowing your own body when you're a patient, about caregivers having that strength. And I think what really, it never ceases to amaze me, even after many years of practice and interacting with patients of all kinds and their caregivers, is the strength that people bring to the table really is inspiring, because I think it gives me energy. It gives us the drive. And we have a sense of urgency. I bring a sense of urgency back to the lab, even for my scientists that don't face patients on a daily basis or have never met them. I'm saying we do this for them. There's an urgency to this. And that really comes from meeting patients and interacting with patient advocacy organizations, strong advocates like yourself who are leveraging social media and really important modes of communication. Of course, I have to bring it back to modes of communication. There's intercellular communication we talked a lot about, and interpersonal communication on a day-to-day basis. And just that's how we exist as society. That's how we support each other. I think we're all in it together. And I think I try to do my own small part. I think everyone here in our team is trying to do their own small part in a way that we hope will amplify and be synergistic and be greater. Whole should be greater than the sum of its parts, and that's always what we strive for. So, and with help from wonderful people like you and your constituents, we're thrilled to just to be invited.
Thank you so much, Dr. Lou. This was a fantastic conversation. So much science and so much knowledge that you shared with us today. Thank you for your time and all the incredible work that you do. And I'm excited to stay in touch and stay updated with the progress. And if you again win that Nobel one day, we'll bring you back here saying that we talked about it here, right? Cheers to
Promise.
that. And thank you, Overcomers, for watching this episode. I'm pretty sure that you enjoyed this conversation. So much new science and new technologies and new advances to learn about. What I said at the beginning of the episode, again, please share this video far and wide with anyone who may benefit from all the pearls of wisdom Dr. Lou shared with us today. And we will be back with the next episode of Connect Ovar Coffee very soon. Until then, you keep inspiring and keep overcoming. Thank you and bye.